We are now moving towards a roundtable discussion. Meanwhile, we're gonna get this poll released, so to get some feedback from the audience while we are getting everybody together on the roundtable. Fantastic. So I'm gonna, first of all, we have the questions open for the audience if they want to ask any questions, and we can bring it to the panel and then make it part of the discussion. But I'm gonna start my first question on the technology. And, you know, Tony, you did a great presentation on what next and all this technology that's are on the horizon. When I looked at the clinical outcome in the 1985, we had about 5% delivery rate. 2016, it went up to 30%. So obviously, this timed with the assisted hatching that came in 88, as you described, the ICSI in 92. But then now we have more technology, and we have the PGTA, we have time lapse. How do you see the impact of technology in embryology? How does this embryology lab look like in 5 years from now, 10 years from now? And I'm gonna give you, Tony, the first word, and then we go through the panel.
Sorry, say that again, Nabil.
How do you see an embryology lab from a technology perspective? How does it look like 5 years or 10 years from now?
I don't know if there's gonna be a lot of changes 5 years from now. I think in my perfect world, I would see that some of these, I don't know what it costs to make an embryoscope. In the 5 years, AI technology helping us out to select embryos. It's challenging for somebody like me because I have my whole career I've been trying to identify the embryo without doing an invasive analysis of it. I was real excited at one time with the microfluidics. And I remember I've heard Gary Smith speak on that a lot, but I haven't seen anything come of that. So but maybe that'll come back again, very much like the endocell. I mean, it was 40 years ago that was done, and when will it become useful again? So 5 years from now, I would think AI using the artificial intelligence with the embryo imaging will be the big thing, and the non-invasive PGT. I don't think that's going away.
Yeah. Kim?
Yeah, I agree. I don't see a lot of big changes coming that quickly. But of course, who could have predicted ICSI? I don't see that we're going to have robotics that soon that are going to be able to do ICSI. But I do think that may be when fluidics are going to come back. Maybe we'll see better methods for culturing, methods that are less hands-on. And so embryologists won't be having to get out embryos as often. I hope that would be one thing. And I hope that there would be some major changes in biopsying that would make it much easier for embryologists to spend less time than they spend now, because I think the biggest strain on embryologists today, I think, is, especially in the US, is the amount of biopsying that they're doing. And if that can be reduced, which I think it will be reduced in the future, it'll help lighten up the load of embryologists.
Very good. Carly?
Well, I'm going to say probably 10 years ago, I saw this video at ASRM. It was in the video competition, and it was robotic ICSI from a Japanese group, and it was completely fascinating. And it's been 10 years, and we've heard nothing since. So when you're talking about possibly robotic ICSI, it has been done. They were using mouse embryos, but it was something that was done. I think the expense of making those kind of robots doesn't make it really viable to bring to market at this time, but as things advance and prices come down, I would like to see, I agree very much that, like the price of things like time lapse should come down. But that microfluidics or movement while you're culturing embryos is probably going to start coming on board. It's been a while, but I think it's going to be mature at some point in the near future.
Thank you so much. Gary, I'm going to ask you the same question, but I'm going to add one more component, artificial intelligence. So the way we have seen it work is that we have those algorithms that look at images and videos, and it will score the viability of the embryo based on certain patterns. But we have more than just embryo pictures and videos. We have PGTA, we have other things, right? Do you see artificial intelligence taking more of a multi-dimensional, components? That's my second question after you giving us a picture of 5-10 years from now.
Yeah, it's funny you say it because that's exactly where I was going to go, Nabil, is listen, as a PGT guy, I'm not an embryologist, so I don't know how the embryology lab's going to look different because I don't spend a whole lot of time in embryology labs, especially not today, which is probably a good thing. But I think for me, the big push for the next, at least for me, the next couple of years of my career working full time is what I call the gray box, right? I showed all kinds of cool data that says if transferred euploid embryo, you're going to get somewhere in the 65 to 68, maybe 70% live birth rate. What happens to the other 30% of embryos? Why don't they implant? That's a gray box, right? And that gray box can be tapped with endometrial receptivity. That's part of the gray box. Other markers of good quality embryos. So a euploid embryo, but which is the best euploid embryo? And maybe that's metabolomics. Maybe that's artificial intelligence and taking PGTA data and marrying that with deep learning and artificial intelligence to look at embryos. I hope that we can find adjunctive technologies that go on top of PGTA to increase the chance of saying to the patient, this is the embryo that has the best chance of implanting and getting them pregnant as soon as possible, right? That's my number one answer. Number two, I think I'm a big believer in we've got to be better long-term at doing IVF, right? For me, IVF is about the only form of medicine that doesn't actually fix anything. It just end arounds the problem, right? It just takes it and says, there's a problem getting pregnant. I'm not going to go and fix that. I'm going to just go around it and say, I'm going to take the eggs out. We're going to do IVF. We're going to put the embryos back in, right? And so I think that there's all sorts of personalized medicine that and algorithms and other ways to look at what goes on in an IVF lab, right? I say this all the time. My wife is an IVF nurse, okay? And so she can sit down depending on which doctor is the doctor of the day in her large practice that's going to make decisions. And she can tell you just from knowledge, Doc A is going to give these patients more meds, these patients less meds. He's going to trigger these patients. Dr. B might be slightly different, and Dr. C might be slightly different. There's an algorithm for that, right? There's a computer that can figure that out better than my wife can or any doctor can that says your best outcome comes from doing this. Stimulation protocols, endometrial receptivity, media for embryos, all those things I think are controlled by some sort of genetics. And I think if we can get to the bottom of genetics and genomics around fertility, we can make every little step of IVF better and get patients, more and more patients pregnant. Tony mentioned it, right? 15% was the best it had when we were all young embryologists or young scientists. Now we're talking 70%. That's fantastic. But why can't we talk about 80, 90, or 100? So for me, I think it's genetics and genomics. And again, I'm a geneticist, so I have to say this, I suppose. But I think there's a lot of genetic and genomic data that can be used to make IVF more efficient, not just picking better embryos, but make the whole process more efficient. So that would be my goal for the next couple of years. And what's going to happen is more data and more technology around making this more efficient.
Exactly. Thank you so much. Jürgen?
Yeah, looking in the next 10 years, it's important to realize what we achieved already. And, we had great presentations today from Tony and from Carly and also from Gary and Kim, where we started and where we are now. That doesn't mean we have to sit back and lay back and be happy and satisfied, but we have to be realistic. There's a lot of factors we might never can have influence on. Culture is for sure something we can get more consistent, or introducing of single-stem media, taking embryos less out, looking at them less. It's all stuff we didn't know 15, 20 years ago. Yeah, we had sequential media, and we thought it's very important to look at every minute at these embryos, and we learn from this. And it's the same with the PGD. Yeah, I'm not a very big fan of PGD for everyone. I'm very conservative, but I would look forward to non-invasive PGD. That would be a powerful tool for embryo selection. I think we still have in 10 years the need of well-skilled and trained embryologists and lab directors. I do a good job in leading these teams. And automatization, yeah, I think I grew up with vitrification, but I think one day we will have devices where we will do that automatically. At the moment, it's hard to realize because storage system, everything is set in place. It will be hard to change more than 50,000 embryos in a different storage system. But that stuff will come, and I'm very positive. And it's my nature to do so. I will not say, no, nothing will change, we will be fine. If we do that 10 years ago, 15 years, we would not have this what we have now. And we do great success around the world.
Absolutely. Thank you so much. Thank you.
Nabil?
Yes.
I'd like to add something to this. One of the most difficult things for us to do is really make advancement in this area. People that work in it, they know day to day how difficult it is to do. We can't just do experiments on our patients. It's impossible. Any experiments we do are very expensive. So where do we even find the time sometimes to do that research, especially when embryologists are worked as hard as they are today? Where is the time for research? I was teaching with some of my EVMS students in statistics, and I must have had about 3 or 4 of them when we were talking about research in the reproductive lab say, how are we ever going to find time to do research? We're too busy doing clinical work.
Yeah, but most of the innovation is coming from technology company pushing the changes towards, embryology lab and genetic lab, and they usually sponsor research and all that. So I think the initiative does not have to necessarily come within the embryology society. It could come outside, and the embryologists will be part of it. As we see all this technology now, the non-invasive and all, it's driven by biotech companies. But I have a question for you though. One of the data that you showed on the impacts of those variables that you have in a laboratory on the clinical outcome, the thaw of the oocytes and the fertilization did not seem to impact, or at least did not seem to be different across clinics. So they're all, maybe it's an optimized, procedure already, but the blastulation and then the implantation and the pregnancy outcome was very so much between clinics. And that obviously is touching not just the embryo culture, but also the PGTA and the transfer technique and the endometrial. How can you control for those variables that are really hard to control for a clinic to be able to perform better?
Right, and I would also add into that how ICSI is performed sometimes can be a difference also, just because you have different variations of how to do ICSI, whether you use a spike needle, a non-spike needle, whether you aspirate, whether you do the kind of scratching pressure technique. There's a lot of different ways to do ICSI. So all those things are difficult to control for. Now, statistically, we can control for those when we do an analysis, but it's very difficult to get an embryologist, for example, to learn a new ICSI technique because there's a learning curve associated with it. And with that learning curve, you don't want your patients to have a lower probability for success so that that person can learn that new technique. So it makes it very difficult. There is not one way to do IVF in the world. There are as many ways as there are clinics. So that's something very difficult. I think we have to attack each part one by one. You know, let's not leave out luteal phase preparation. Look at that. And I think you can really determine very readily by looking at data from the past whether your preparation for the endometrium is a good preparation or whether it's a poor preparation. And then you have to break it up and look at each individual area, and it's going to take time using your KPIs for specific embryologists, for example.
Thank you so much. Any other comments from the panel?
I'd like to add one of the things, I mean, you know, talking about going forward, and I know, and maybe Gary can elaborate on this too. Like when I'm teaching my students how to do biopsy, one of the things, and we do have the mitotic errors, but I've always been under the school of thought that the mitotic errors are less frequent than the meiotic errors that we have before, while the egg is being ovulated. And so that 80% of our aneuploidy comes from that first meiotic production of chromosomes, which I try to emphasize to all my students, all my teammates in the labs I work with, that you aren't making them abnormal. You know, if we can get the things like pH, osmolarity, temperature, those things we can control. But the oocytes are abnormal before we get them. So all these technologies we're adding to this, the AI, it's not that there's not a magic pill that's going to make the embryo normal. What we're spending the money on is deciding which one it is. As Gary said, there's 30% of those that aren't implanting. It's the seed in the soil. The genomics is supposed to tell me I got a right seed. You know, Kim just talked about the soil, but the money we're spending on these new technologies to make IVF even more and more expensive is trying to find which one. So it's not so much of we're making it better, we're just getting pregnant faster. The time to pregnancy, the time to delivery, you have to spend money on. You can have it cheap, good, and fast. You get two of those. If you want it cheap and good, it's not going to be fast. You're going to have to spend, you're going to have to do more and more IVF cycles. So
yeah,
it's my take on a lot of what we go through every day.
Very good. Any other comments before we jump into the next question?
Yeah, this is a very good point, and Tony made. You know, even we stuck today with 70%, or some people do 80%. People really need less attempts to get pregnant. This is sometimes overlooked. And you know, this is very positive, of course, for the patient ourselves, gives us more motivation, we are more positive, but patients also less stress level. You know, we know it all affects very much outcome, not just a good embryo or the good preparation of the endometrium. So it's a lot of things where we pull into this. Good point.
Yeah, and time is money. Time is important for patients, I think.
Yeah, especially patients get older. You know, they are not 35, they are 40. So every year counts.
Yeah, exactly.
Every month counts, right? It's not just years, it's months.
Yeah.
Carly, I have a question regarding one point that you described in your presentation. It was the dry versus humid environments for embryo growth, for embryo growth. And what I don't know, because you've shown two different studies that show there is no difference, and more studies and bigger studies that show that there is a difference, that humid environments is actually better. Have they computed the PGTA results in those studies?
No, and actually that would be really interesting, because you know, when you're showing differences between laboratories in the percentage of euploidy that they have, I always want to go to culture conditions. I do have data. I have a lot of data from 2 different culture systems, and analysis of that data shows that one of my media was giving us a higher aneuploidy rate. It's very interesting, and it's could be culture induced. And so none of the data that actually was just looking at humidified versus non-humidified included any PGT data. But I think that would be very, very interesting, because there has to be something that's influencing the amount of euploidy when you're looking at your big data, and you can pick out labs that have lots of euploidy or a little bit of euploidy.
Thank you so
So there
much.
has to be something induced in the laboratory.
Yeah, and I think there was a study from CCRM not too long ago showing that the culture media does impacts aneuploidy rate. Not sure if those aneuploidy are biologic aneuploidies or just stress and degradation and all these things that will lead to a similar effect. Gary, what do you think? Does culture media or other culturing conditions impact aneuploidy rate?
You know, I think that's hard to answer at the moment. I was going to say, I saw a really nice talk by Dave McCullough on a different platform that I won't mention, but a webinar that Dave did. And Dave looked at everything that happens to an egg from the moment it's an egg, and everything from the sperm from the moment it hits their laboratory, and looked at aneuploidy rates based on who did the ICSI, who did this, who did that, you know, those kinds of things. And he's seen clear differences just in people, right? So somebody, I think Jürgen mentioned it, or maybe Kim mentioned it, that, you know, I could teach two people how to do something, and a year from now, they're both going to be doing it slightly differently than exactly the way I taught them. Doesn't make it wrong. It just means that, you know, things drift. And Dave was able to show that clearly different people doing different techniques in the laboratory are impacting the aneuploidy rates, right? That same group has looked at aneuploidy rates between different IVF centers and donors. So yeah, I think everything we do to an embryo could have some impact on mitotic error. Tony's right, meiotic error is meiotic error, and that happens mostly in the woman in her ovaries long before we ever see the egg, right? So there's some really cool work being done by a couple of groups looking at, hey, let's not just test for aneuploidy, let's fix it, right? So Terry Hassold is sort of the father of meiotic aneuploidy. If you ever get a chance to look at any of his work, him and his wife, Pat Hunt, they've got some ideas around why meiotic aneuploidy happens in women's eggs, and that would be something that we might be able to fix down the road. So I don't see how biopsy and culture conditions can't impact. It has to be impacting in some way these mitotic errors. I don't think we understand it enough yet. And as Kim said, it's kind of hard to do research on your patients, right? But there's not a whole lot of money in doing research, basic research, when you can make a lot more money doing IVF. And so that's the other dichotomy I think we see a lot of is, you know, where is the basic research on embryology going to come from? Because there's not a whole lot of people that are paying a ton of money to do the basic research. It happens as we go in the lab, and that's tough. And so I'd love to see more programs like EVMS and some of the other programs, like the training group that Tony does, the training system that Kathy Miller has down in Florida. There's a group in California getting ready to open up a training facility. I think all those places are great places that we might see some basic research to understand more about what goes on, you know, what we do in our lab and what you do in your embryology lab and how that impacts the genetic results that we see.
Gary, can I bring up something? I've brought this up before, and my question is, we see that there are differences between laboratories in aneuploidy rates. Could it also be due to how we are performing the actual biopsy? We're not affecting the actual aneuploidy rate of the embryos, but how people are doing the biopsies affect the results. For example, if someone does biopsies and has problems with the biopsy sticking to the glass pipette and doesn't then change that pipette between biopsies, as is common in the US, then they get a reading that says it's either mosaic or aneuploid, depending on how many cells they get.
Right. Yeah, not only that, you know, I had a long talk with Barry Baer 2 years ago, I think, that you can't tell me, listen, I'm not an embryologist and I don't ever claim to be one. I've done a little bit of biopsy just because I was making fun of somebody that I didn't think did a very good job. And he said, okay, smart guy, you do it on some spare embryos. And it's really hard. It's really, really hard. So I don't minimize that. But you can't tell me watching people biopsy that you're cutting right down the cell junction and you're not harming either one of those two cells. You just can't tell me that sometimes when you do biopsy that you're not cutting a cell in half and DNA is spilling out of that cell. And that's what looks like it's mosaic, right? It's not really a mosaic embryo. You just sliced and some of the DNA came out. From the fish days, we know, right? From the fish days, it's very clear there are micronuclei that contain chromosomes, right? We don't know that anymore because we're just sticking everything into a tube. So Kim, I'm 100% certain that it's not just growing embryos, it's the way we manipulate. I'm convinced, and Nabil, I don't know how you feel about this, but I've been in labs where there's one person that's doing biopsy, and then they leave the biopsy samples just sitting in the incubator. I mean, sitting on the bench, right? If that's a heated bench, they're now taking cells that were perfectly happy as a tissue in an embryo, ripping them off the embryo and sticking them for 2 hours on a 37-degree bench. What's going to happen to that DNA that's in those cells? That DNA is going to start breaking down, right? So I think it's everything about not only what happens to the embryo while you have it, but everything during biopsy and after biopsy and transport and things that go on in our own laboratories. I try to cover with that little mosaicism story of I might think 3070 is the best answer and Nabil might think 2080 is the best answer. I can't tell you which one of us is right. I can tell you why I think what I think, and Nabil can, I'm sure, tell me why he thinks what he thinks. But if you sent the same sample to one lab, Nabil at 2080 and me at 3070, we could get very different answers that are both right according to our way that we analyze embryos or analyze results. And so I think it's really critically important to have these conversations between you and your patients, between you and your staff, and you and your laboratories that you use to make decisions about embryos, be it PGT or media or anything else. I think everything we do impacts the outcomes and results. And if you want to put your head in the sand and think that it doesn't, I think you're absolutely wrong. And I think having these conversations is the best thing we can do, is be open and honest about what goes on in my laboratory, what I think, and I know Nabil feels the same way. We may not agree. I don't know where Nabil feels on cutoffs, but we might not agree on cutoffs. Can't tell you who's right, but having that conversation so that the end user understands more about the results they're getting, that will impact outcomes as well.
Thank you so much. We'll have a little bit of time to talk about mosaicism in the next question. We just got the results from the poll, and I'm gonna just read the results. So we have asked this question based on the topics that were discussed today. We ask if embryologists are using dry or humid incubators. And so dry incubator accounts for 42%, humid incubators accounts for 58%. So looks like the majority are using humid environments. The second question is, it was supposed to be, do you view your director as manager or leader, either or, but the question went that way. So manager or leader in one description. 68% said yes, and 16% said somewhat yes or no. Jürgen, what do you think about this response on how embryologists view their director?
Oh, it makes me very happy and proud for all of us that maturity has a good feeling in their leadership, but 32% are in between, is still a lot of work to do. And we didn't learn that, right? We were trained doing ICSI and all that other stuff, freezing embryos and transfers. But having a team like myself, up to 20 people and more, this is a different magnitude, and it is something we have to learn. And I realized which is an important part being successful, having people enjoying coming to work and love their work, developing passion, don't see it just for making money. That would be legitimate, but it's just not enough to sustain longer. And we see more younger embryologists just moving around quite quickly, focusing on money exclusively. And after 2 years already asking for money, you know, I didn't see after 10 years. So this is a changing world. I realize that I have 5 kids. I see that by myself. But, you know, this is where we might have to be resistant and have to understand and keep what we think is right. This is changing. There is no questions. But for your team, as long I do my lab, I definitely will work on this in keeping values I was growing up, and I think they were right. I got it from my parents, and I will keep that to my children and also to my staff. And I know they come with different expectations and some of them different behaviors, but you know, it's always a challenge. Even I had a lot of people that were not easy, but this is a challenge for me. I don't give up.
Fantastic. Thank you so much. We missed just one question, which was what was your volume of PGTA? And either 75%, 50, 25%. So 21% have more than 75% PGTA, 26% have more than 50, and 37% have more than 25. So there are 16% that don't use PGTA testing. I think this is a reasonable figure. I think I was expecting something similar. So the majority are sending, majority meaning 47% are sending more than 50% PGTA testing. That just tells you people do believe in PGTA and they are using it towards that advantage. We are very close to the end of the webinar. I have one more question to you, Gary. Very fascinating, the story of an embryo that was not detected to have mosaicism in PGTA end up being a mosaic. My impression has always been we are missing a lot of mosaic embryos that go into implantation, and maybe we never see them because they don't get tested. But what surprised me the most is that the mosaicism rate in miscarriages is only 3%. However, when you look at mosaicism in PGTA, you get all kind of figures. You get low mosaicism, high mosaicism, you get up to 20%, and other labs have 3%. Where do you stand as far as mosaicism rate in PGTA?
Wow, that's do we have an hour? Because I could go for an hour on that one. I'll make it as simple as I can. When I was part of the group that wrote the guidelines, right? And I was very vocal, not surprisingly, for anybody that knows me knows I'm pretty vocal. And I had a massive email argument with a few very famous PGT people about this thing that I'm going to say. If you look at the STAR trial, one of the things that really stands out to me in the STAR trial is the mosaicism rate between genetics laboratories, all using the same platform, right? If you look at the one-pager Illumina produced, there's a chart that shows it. I find it very hard to believe, Nabil, and maybe you disagree. I doubt you do, because you and I have talked about this a lot. I find it hard to believe that you can give 3 or 4 labs, good labs, supposedly good labs, the same exact platform. Now, the patients are different because they're from different IVF centers, different countries, but I don't think that the patients could be that different, that one lab could produce a mosaicism rate of 4% and one lab could produce a mosaicism rate of 27%. What that tells me is what's going on in the genetics lab is creating a mosaic looking embryos, and that I think not all mosaic embryos that we see in our lab are really mosaic. Ultimately, what we're doing, no matter how you do PGTA, generally, if you're doing whole genome at least, is taking a representation of 3 cells or 4 cells or 5 cells, that it's whole genome amplified, library prepped, run through a system, and then analyzed 1 megabase at a time, right? it's a mathematical algorithm-based calculation of what that original 4 cells was. It's not an actual one-to-one diagnostic test. So my answer to that question is some proportion of the mosaicism calls that we're seeing today and mosaic embryos are not real. There's no doubt about it. This data set that's going to come out with 800 embryos that have been over 800 transferred embryos that are mosaic is going to show you. Some of them clearly are. There's higher miscarriage rate in the mosaic embryo transfers, but there's a lot of mosaic embryos that get transferred that are perfectly normal. So it could be that the mosaicism is just stuck in the trophectoderm and it's perfectly fine. But I think, personally, I think some of the mosaicism comes from what we do in our labs, not from the embryo. I don't know if you agree with me, Nabil, about that or not. I think it's a question we have to answer, and we have to be open and honest about it.
Yeah, I think from my perspective, the control that I have is 1,000 case study from a miscarriage, where they looked at mosaicism rates, and if it's 3%, it's hard to believe that PGTA will be a lot more. On the other side, when we overlap the data between PGTA, the aneuploidy frequency, right, between PGTA and miscarriage, they look very similar, which means that when you transfer the embryos, the endometrium is not doing any selection against any particular abnormality, and mosaicism is not an exception. Meaning, if you have it before, you will see it after. And so that's why I believe it has to be within 2 to 3% that reflects what we see in CVS.
Yeah. There's a group in the Czech Republic that's doing some work, not really around mosaics, but around segmentals, because for me, segmentals are the other problem in PGT. Not all segmentals are real. So they've created an algorithm. Now it's an IVF center that has their own PGT lab. And what they've done is if they see a segmental change, they rebiopsy that embryo. And if it comes back euploid, they're transferring it. And it's within a study, so the patients are being counseled, and they're going to be able to produce the number that says this percentage of segmentals are real and this percentage of segmentals are not real. I think we could do something similar with mosaics. I'm on a subcommittee at PGDIS looking at putting together a database so that every mosaic embryo that comes back could be entered into the database, and you can find out what happened when it got transferred, what happened if someone did follow up on that embryo and did intercell mass versus multiple biopsies. 3 to 5 years from now, I think we're going to know a lot more about which embryos are really mosaic and which embryos are not, and which embryos really have a segmental change and which ones don't. I think for me that what's really clear from all the work I've seen is if you do trophectoderm biopsy and you see a whole chromosome gain or loss, it's 98 to 99% accurate, right? That's for me, that's very clear. And I think euploid embryos, the accuracy is quite similar. So I think for whole chromosome gains and losses, I think we're really, really accurate with PGTA. I think with mosaicism and segmentals, we need to get better. We need more information and more data. And that'll only come, by the way, if we all knock down these walls, and Nabil, you and I work together, no matter which lab I work at, Tony and Jürgen and Carly all work together with their laboratories. We all have to talk more. We all have to work together to get to the bottom of this question, because that will ultimately make this test more reliable. More people will want to do it. More people will get better results from it, and more people will get pregnant ultimately. And so, listen, I spent lots of time competing against a lot of people, and I'm done with that. I'm here. For me now, the next few years is all about, let's all work together and collect data and make the technology better and make it better for patients. That's my hope, at least.
Thank you so much. As far as embryology goes, what are the improvements that you guys see in the horizon? What needs to be done to improve outcome? This would be my last question before we wrap up the webinar. So it's an open question for everyone.
I think improvements in endometrial receptivity are kind of important. It's not one size fits all when they're doing like preps for FETs. You know, people get really used to using a box, like boom, 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 we're going to do this, we're going to do this, we're going to do this. And sometimes that may need to be more personalized for a patient. So I think that, you know, a lot of things that can be influential or kind of out of our control, but that could absolutely 100% improve outcomes. And there's a paper that you've said several times. There's a paper that's like, what matters in the IVF lab? Everything. And it's like everything you do matters. And the whole team, it's a team, has to participate fully to maximize results.
Yeah. Tony?
Yeah. Well, what I want to talk about a little bit about what Gary said about mosaicism. Like, in our lab, and I was actually talking to Marlene Engel the other day. We were saying that, she was asking about some consenting, and the problem is, what do we do with these mosaics? And I have a discussion with my docs. I say, well, if it was my sister and she's 45 and she's, mosaic for chromosome 1 or something, I'd transfer it. I mean, she may not, it might be the only chance that she has for getting pregnant. But, we're at this point where nobody wants to transfer these embryos. So if there is a database, if somebody, that's really challenging. And I have the fortunate opportunity of, working in the Aspire centers, where I see a lot of other centers' embryos. And you both mentioned, like, one lab having a 4%, another lab having 27%. But I'll look at one lab in the Prelude network that has, they freeze on average of 6 embryos per patient. And in San Antonio, we freeze on average of 4.5 embryos per patient. Does that mean that other center is better at growing embryos than I am? Or are they just biopsying more suboptimal embryos? So I don't think it's all the genomics labs. I think it's also, some of the pressure that goes on to the laboratory from the doctors to freeze a lot of embryos that, just because you got a biopsy and store doesn't mean it's going to be a good embryo. But it would be nice to have the guidance on what to do with these mosaics, because one of the data supports that we've transferred a few low mosaics, but what's the difference between low mosaic and high mosaic? And I don't know. And so that's kind of where I am at with that.
I think one of the problems that we all have with mosaics is that genotype doesn't necessarily say what the phenotype is going to be. So if you have someone that's a mosaic, you can't really accurately predict what the phenotype would be, whether it would be a detrimental phenotype or a phenotype that's not a big worry. So I think that's part of the problem with, like, mosaics and the fear of transferring mosaics, is because right now we don't have the data that could accurately predict what that phenotype is going to be.
Yeah, I think that
100% of the embryos are mosaic, though. Like pre whole genome, pre next gen, I had biopsied intercell mass, did immunosurgery, intercell masses, and trophectoderms, and all I could do was fish at the time. 100% of the embryos were mosaic, or technically aneuploid based on the analysis, but.
Yeah, but fish is tough because, listen, if you take a lymphocyte culture and you spread those cells on the slide and you put down even just one probe on 200 cells, you're only going to get it back an accuracy of about 92% of the time. Is the fish going to give you the right genotype of those cells? So that's for one probe on 200 cells. You mix 5 probes together on one cell. The genotyping accuracy is somewhere in the 65 to 70% range for PGT back then. So, Tony, I don't disagree, but I don't know that every embryo is mosaic, but I think a lot of embryos are. I think for, Carly, what you're saying, I think the Cameron paper is for me, it's really important for everyone to look at. That was a low-level mosaic of a chromosome that I would transfer that embryo all day long. Monosomy 2 is not going to implant and make a normal live birth. And sure enough, that's what happened. And I think that should give us pause, and that should give us information. And we should all think a little bit harder about transferring these embryos, because in the end, that was an embryo that obviously was truly mosaic. It had some sort of an early gain loss, because you see the biopsy was monosomy, the amnio is trisomy, the kid is monosomy, right? So that tells you both cell lines exist in that child somewhere. So the gametes are likely to be a different percentage aneuploid or mosaic than maybe other cell types. So I think it's really interesting. It's really difficult, but I think it's something we need to look at. And again, this is where a database would be huge for everybody. It'll help everyone.
Thank you so much. Kim, either mosaicism, or you can tell us what needs to be done in the embryology lab to improve further, or is there any window for improvements?
Okay, I'd like to take improving the embryology lab. I think two things need to happen. First of all, I think we really need to try to reduce some of the risks in the laboratory that are being faced by embryologists because they are just so overworked. Part of that is every lab, it should be required, has a witnessing system, an electronic witnessing system. This is required in Australia, for example. Doesn't matter what clinic you are. I think we need that. Yeah, and I think the other thing that we need is we need to make sure that our cryopreservation systems are monitored to the maximum, because just one failure will make a clinic go broke from the amount of money they will pay from a suit. So I think it's well worth to get the best system out there to make sure you have those cryo systems monitored. And like I said, the third thing was somehow you've got to value the embryologists most. The clinics have to value them and make sure they're not overworked. This means you should have embryologists doing nothing sometime so that you will have enough room for growth.
Thank you so much. Jürgen?
Yeah, actually, an excellent comment by Kim on the end. We are embryologists, so we always focus on what we can do best. That's right. But to success, we need another department, that's our physicians. And I think, on a long run, it's very important to build a good relationship, a mutual respect for what each does and how important it is. Not so much just us, we are important, but it needs more than just us. Consolidating results, making embryologists consistent in their skill, possibly, if possible, improving, learning new techniques. Yeah, that's pretty much. But as Kim pointed out, we really facing a lot of work that, to me, in my lab, this is not necessarily linked to ICSI or embryo culture or carrying embryo over in another dish or transfer. It's a lot of paperwork. It's a lot of consenting. This paperwork is growing over our head. And for every little step we have to do, we need now a signature or something else to be allowed and to make it legitimate. So it's a lot of things besides we talk about here that affects our daily work. And this is sometimes very stressful. Missing consent, even the patient is ready for retrieval, missing blood results, all that stuff that should be in, that happens every day. And that needs improvement too.
I agree with Jürgen, but I also want to make a statement about witnessing. I am a longtime user of electronic witnessing. I am a huge proponent of it. We use it at RMI for PGT. We use it for freezing and thawing embryos. Every single time an embryo is looked at, it is tracked on that witnessing system, and I cannot for the life of me understand how these laboratories with one or two people working in them do their work when there's often just one person there where there's no one to witness. Oh, there's these people that go to labs that they'll do 20 retrievals in a week, and their you know, off-site. They just come in to do the retrievals and it's just one person. Who's watching what they're doing? Like, to me, that's crazy. I don't understand why people in the US do not embrace technology that actually improves and increases the workflow, because you're not interrupting someone. Hey, come over here and witness this. And you can work by yourself with extreme confidence. You don't have to have two people come in on a Saturday to biopsy one embryo. One person can do it because there's some system monitoring it. I do not understand it.
Thank you so much. Well, we are coming to the end of the webinar with this. We have one more poll to read. We have asked the audience if they would be interested in a multi-center spent media research project. 47% said yes, 29 said maybe, 24 said no. We asked them if they find this symposium helpful. 82% said yes, 18% said somewhat. And we asked them if they want to see a symposium like this in the future. 100% said yes. This is definitely the results of your expertise and your contribution. I would like to thank each one of you for participating and for bringing your expertise. Thank you so much, and I will see you in a next symposium. Thank you so much, and have a great weekend.
Thank you.
Thank you, Nabil.
Bye. Bye, everybody.
Be safe and well.
Bye, guys.
Bye, everybody.
Bye.